Hello, everyone. Hi, Anam. Thank you so much for a warm welcome. Hello, everyone. Thank you so much for being here with us. We are so grateful to have you, and we are beyond thrilled to be with you at this moment for the session. Thank you so much for being here. Hi, Aisha. Hi, I hope you're doing great. Hi, Manisha. Hi, Tareem. Hi, Irsa. Hello, Varsha. I hope you're doing great. I hope you're all excited for today's session as much as I am. Yes, that's great. Well, I hope the excitement stays high throughout the session and we come out with a fruitful session, both of us having learned something and having gotten to know each other. And let's hope for a great time together. Hi, Madia. How are you? Hello, Simreen. Hi, Red Roses. I hope you're all great. Okay, so today we will be covering ectopic pregnancy. Along with that, towards the end, we'll also touch upon a little bit about how to efficiently and effectively prepare for Part 2 MRCOG, while working, while taking care of your chores. And, as doctors, I understand that we're all busy and we've got 10 things to do. But along with that, this is one exam that needs to be done. And trust me, I believe that Part 2 MRCOG is the most difficult part of the Part 1, Part 2, and Part 3 of the 3 exams that are there. And it does require a lot of efforts. But if those efforts are directed in the right way, if there is some sort of somebody guiding you in the right direction, I think it becomes a lot more easier. So with that hope, let's begin ectopic pregnancy. And yes. All right, so let's start with the agenda. So we'll be talking about the definition and the epidemiology of ectopic pregnancy. Then we look at the clinical features and how to diagnose it. We'll see that what are the applications and limitations of the scanning that is done, and also the beta HCG testing. Along with that, we will understand what are the different treatment options that are available and which option to choose in which situation. After that, we'll be solving a couple of questions, more so to understand the approach to solving a question. What exactly should be going on in your mind when you're dealing with these questions? I'll take a few doubts after that, and I'll tell you the course details, and we have a surprise for everyone who's there at the session. All right, so let's begin. I'm very aware that you all know what ectopic pregnancy is, right? But to start off, ectopic pregnancy is something wherein is a condition wherein the fertilized egg, instead of being implanted here in the uterine cavity, it is implanted outside the uterine cavity or outside the endometrium of the uterine cavity. It could be anywhere, it could be in the tubes, it could be in the ovary, it could be in the cervical canal, or anywhere in the abdomen as well. All right. So now they say that the Green Dot guideline says that the incidence of ectopic pregnancy in the United Kingdom is 11 by 1,000. Please note it is 11 by 1,000 and not 11%. It's 11 by 1,000 or 1.1%, a very important incidence which has to be on your fingertips, one of the incidences that needs to be remembered. Okay. Now, the incidence of ectopic pregnancy in women who are attending the early pregnancy unit is around 2 to 3%. The 2019 MEBRACE report said that there were 6 maternal deaths due to early pregnancy complications, and out of them, 5 had ectopic pregnancies. All these 5 patients had a mortality 48 hours after the diagnosis, and it was all of them were because of ectopic pregnancies. Now, there are certain conditions which increase the risk for an ectopic pregnancy, like any sort of tubal damage, especially if there's been surgery for endometriosis, if there's been any surgery which is altered the normal anatomy, would lead to increased risk for ectopic pregnancy. History of PID, any previous ectopic pregnancy, endometriosis, in vitro fertilization, and smoking. These are the risk factors we need to know, which would increase the risk of having an ectopic pregnancy. Why it is important for us to know the risk factors is because of the way they will put out the question, right? In the exam, the question will start with something like 26-year-old lady who's a known smoker. And as soon as you are thinking of the risk factors, your mind will take you towards ectopic pregnancy. And that is why it is important to remember the risk factors. But in 1/3 of the cases, ectopic pregnancies will have no known risk factors, right? That's why it's very essential for us to have a low threshold for diagnosis of ectopic pregnancy. It could happen in women who have no risk factors at all. Now moving forward on how to diagnose ectopic pregnancy. Now these patients who have ectopic pregnancy will come to you with missed periods, with periods of amenorrhea. It could be 6 weeks, it could be 8 weeks, it could be 9 weeks. They could have symptoms of pain in abdomen. They could have bleeding per vaginum, spotting per vaginum. There could be other uncommon symptoms like dizziness, fainting because of bleeding. There could be shoulder tip pain. There could be urinary symptoms. There could be history of passage of tissues, breast tenderness, GI symptoms. I'm sure that you've all managed tons of ectopic pregnancies in your clinical practice, and you're very well aware of the clinical features that they will present with. Now, when you go ahead and do the examination, the first thing that you do is the general physical examination or the overall examination of the patient, wherein if there has been a rupture, if there has been bleeding, intraperitoneal bleeding, the patients could present with pallor, they could present with tachycardia, hypotension, shock, collapse. But if it's an early pregnancy, they could have no obvious symptoms at all, probably just some tachycardia or nothing at all. When you do a systemic examination, you will be able to see some guarding rigidity if there has been a rupture inside, or otherwise you can just have probably some rebound tenderness or some abdominal distension if there's been intraperitoneal bleeding. If not, I would request everyone to keep your mics on mute if you do not have any questions, because otherwise it would break the flow of the session and we'll all end up lagging behind in terms of time. All right. So when we go ahead and do a pelvic examination, we can get signs of pelvic tenderness, adnexal tenderness, or abdominal tenderness. We can also get symptoms, signs of cervical motion tenderness. All these things together as a whole should take you towards the diagnosis of an ectopic pregnancy. Now, you have, from your clinical features, you've come to a stage wherein you are thinking of an ectopic pregnancy. Now, how do you confirm these findings with the help of an investigation? The first thing that you want to do is a urine pregnancy test. More often than not, the urine pregnancy test will be positive. If not, it could be faintly positive. The next thing and the most important investigation in an ectopic pregnancy is the ultrasound. In terms of the ultrasound, you want to get a transvaginal ultrasound. I've put the Green Top guideline picture here, which says transvaginal ultrasound is the diagnostic tool of choice for tubal ectopic pregnancy. Now, tubal ectopic pregnancies should be positively identified, if possible, by visualizing an adnexal mass that moves separately to the ovary. This is what the Green Top guideline says. The first and the most important diagnostic tool in an ectopic pregnancy is a transvaginal ultrasound. It has a sensitivity of 87 to 99% and specificity of 94 to as high as 99.9%. Now, what you actually see in a scan or an ultrasound is an inhomogeneous or a non-cystic adnexal mass. Now, this is the most common finding. Along with this, you'll also be able to find an empty extrauterine G-sac, which could be present in 20 to 40% of cases. Now, a very interesting thing that is present in 20% of the cases is known as a pseudo-sac. Now, this is usually seen inside the uterine cavity, and this is a collection of fluid. Sometimes people can misunderstand the pseudo-sac as an early intrauterine G-sac. For us to be able to differentiate a pseudo-sac from an early pregnancy, we need to look for two signs that are present in an early intrauterine pregnancy. Now, these signs are intradecidual sign and a double decidual sign. So what exactly is an intradecidual sign? This is described as a fluid collection with an echogenic rim, which is located within a markedly thickened decidua, okay, on one side of the uterine cavity. Now, the double decidual sign, this is described as an intrauterine fluid collection surrounded by two concentric echogenic rings. I hope the ultrasound diagnosis is making sense. Ultrasound, or the TVS, is the first investigation and the most important investigation for diagnosing ectopic pregnancy. You should be aware of the features that you would be seeing on the ultrasound. You should be aware of how to be able to differentiate a pseudo-sac for an ectopic pregnancy versus an intradecidual sign or a double decidual sign for an early intrauterine pregnancy. Okay, I hope these things are clear. Before we move ahead, I want to tell all of you, anytime you have a doubt, please do stop me. We will discuss that point. We'll make sure that it's clear for all of you, and only then we'll move ahead. Okay. So even now, if anyone has doubt, please let me know and we'll discuss it and only then move ahead. Okay. All right. Somebody has a message. No, ma'am. That's great, Samreen. Okay. So sometimes, patients come to you a little early. For example, patients come to you around 4 to 5 weeks of gestation, and they have a they have red roses. Has a question. What is the difference between the two signs? In terms of the difference between a pseudo-sac and if you want red roses, you could first of all put your right name. It would be better for me to call you that way. And the second thing is, if you could unmute yourself and ask the question, that would be great too. You want to know the difference between a pseudo-sac and the intradecidual sign, or the difference between an intradecidual sign and the double decidual sign? A standard range in Excel file is a collection of cells like the cells. Ma'am, it's disconnecting again and again. Khadija, I think you can, I hope my connection seems to be okay. If you could log out and log back in, that would be great. Or is there a problem with connection for everyone? No, okay. Okay, that's perfect. Thank you so much for letting me know. Okay, so if you're asking for the difference between the intradecidual sign and the double decidual sign, it's very simple. The double decidual sign will have two concentric echogenic rings. Okay, there are two echogenic rings, whereas in the intradecidual sign, it is just a fluid collection, which is just one rim, and it is located quite inside the thickened decidua. Okay. There would be a thick decidua, which is especially because there has been a positive pregnancy, which has led to the thickening of the decidua, and it would be quite inside it. Yeah.
Okay. Hi, ma'am.
Hi. Yes.
This will tell you, okay, whether this is this will be the
Rabia.
Rabia. This will be the intrauterine gestational sac, and this wouldn't become an ectopic pregnancy.
No, Yes. So what you understood is right. If it's a pseudo-sac, if you're looking at a pseudo-sac on a scan, and if you're suspecting an ectopic pregnancy, probably when you go to the adnexa, you will be able to see features of an ectopic pregnancy in the adnexa, right? But having an intradecidual sign or a double decidual sign means that this is an early intrauterine pregnancy or a normal pregnancy, which will grow into a normal, it'll go on and have a normal antenatal course. But a pseudo-sac probably indicates that, oh, there is ectopic pregnancy or there is something in the adnexa which you should be looking at. So it's important for us to be able to distinguish between the two. Okay, even though they look similar, we need to know that they're two different things and they mean two different things.
Like, so the pseudo-sac will be present in the early intrauterine pregnancy. This you
No.
mean?
Pseudo-sac would be present in ectopic pregnancy.
Okay. Thank you.
Yeah.
Thank you.
Pseudo-sac in ectopic and intradecidual, double decidual in early intrauterine pregnancy. Okay, I've written it here. Yeah.
Okay, thank you, ma'am.
Thickened decidua, is it same as ET? Sometimes they mention thickness of endometrium in US. Yes, endometrial thickness. That's right. That's right, Maliha. All right. So moving ahead, sometimes I was saying that sometimes if the patient comes early on, for example, if the patient comes around 4 weeks, 5 weeks, the beta HCG is quite low. It is in the ranges of, say, 600, 800, and you get a TVS done and you're not able to localize a pregnancy. What do we call this condition? We call this condition pregnancy of unknown location. Okay, so you don't know where exactly the pregnancy is. If it's an intrauterine pregnancy, well and good, you can allow it to progress. But if it's an ectopic pregnancy, you need to be cautious and you need to know what management you would be doing moving ahead. Another option that could happen is it could be a pregnancy that's sort of miscarrying and that's not going to progress. Okay, so how do we distinguish pregnancy of unknown location from an intrauterine pregnancy from a miscarriage? Let's look at it. Okay. All right. So we have three things. The patient that I was talking about comes to you. You get the beta HCG level. She came to you today. It was 800. If the patient is absolutely stable, you tell her to repeat the beta HCG level 48 hours later. So we are here. If the rise in beta HCG is more than 63% in 48 hours, this probably means that the pregnancy is intrauterine. So the patient's beta HCG today was 800. You repeated the beta HCG 48 hours later, and it probably became 2000. This is quite a reassuring sign. And this means that this pregnancy would most probably be an intrauterine pregnancy. Now, what you would do in this situation is get a TVS to determine the location of the pregnancy, which would be between 7 to 14 days. If you think that the beta HCG level is more than 1500, you could probably get a scan earlier as well, right? Now, the next thing is you got the beta HCG done today and it was 800. You repeated it 48 hours later and it became 200. That means the fall in beta HCG was more than 50%. What this means is we are here. It means it's probably an early pregnancy loss or a persistent pregnancy of unknown location. Now you're mostly thinking of a condition wherein the pregnancy is not going to continue. And what you're going to do in this situation is ask the patient to get a urine pregnancy test 14 days later or 2 weeks later. If it's negative, it means that the pregnancy has miscarried and you don't have to do anything. But if it comes back to be positive, you tell the patient that you have to go and visit the early pregnancy assessment unit within 24 hours. Okay. Now this is regarding persistent PUL or an early pregnancy loss. Now coming to the topic of discussion, something that is important to us. In an ectopic pregnancy, the decrease in serum beta HCG level would be less than 500 and the increase would be less than 1600. What I mean by that is if today the beta HCG was 800 and you repeated it after 48 hours, it would probably be 1200. Okay, so the increase is not more than 63%, and there is no decrease. If there was a decrease, it would probably be 700 or something, which was not less than 50%. So it would be borderline. So anything that falls between a fall of less than 50% and a rise of less than 63% means that we are dealing with something like an ectopic pregnancy, and this patient needs to be referred to an early pregnancy assessment unit for further review. Any questions here? Any questions, any doubts? You want me to repeat it? Okay, no doubts. No doubts can mean only two things. Either everything went above your head, or I was making it very clear and that there are no doubts at all. It's clear. Okay.
Very clear. Very clear.
That's perfect. Thank you, Mona. Okay, that's great. Okay, let's move ahead then. Right. So initially, people used to say that doing a laparoscopy is the gold standard, and that is the most important investigation, which is going to confirm the diagnosis, or it is the gold standard for diagnosis. But now that notion is no longer believed, because almost 3 to 4.5% false negative laparoscopies have been reported. And it is an unnecessary investigation, it is an unnecessary intervention, and the patient has to get admitted. It's unnecessary added cost. And therefore, this notion has now been replaced, and the gold standard now is the TVS. Also, there is no role of getting progesterone done in the diagnosis of ectopic pregnancy. Okay, so I've got 3 questions for you. Which investigation, if they ask you in an exam, which investigation is for definitive diagnosis of an ectopic pregnancy? Be active in the chat box, let me know, or you could unmute yourself and let me know.
TVS,
Yeah. Okay.
ultrasound.
Perfect. All right. So you'll see something like an adnexal mass that moves separate to the ovary. Next question is, which investigation is important for planning the management?
Serum beta estrogen.
Beta HCG.
That's absolutely perfect. Great job. Okay, so beta HCG is for planning management. This line is from the Green Top guideline. I'm so sorry, just give me 1 second. I'm so sorry for the disturbance. I'm back. Okay, so this sentence or this line is from the Green Top guideline. It says that the serum beta HCG level is useful for planning the management of an ultrasound visualized ectopic pregnancy. There is no role of serum progesterone. It's perfect. You've already read the next question and answered it. That's great. Absolutely great. Okay. So definitive diagnosis TVS for planning management beta HCG and no role of serum progesterone. Okay, perfect. All right. Now let's move to the management of tubal ectopic pregnancy. Before we move ahead, any doubts up till here or any questions that you want to ask?
Excuse me, I just want to ask something. I want to ask what is the difference between like pregnancy of unknown location when we say, and when do we say it is early pregnancy? Like when can we classify as pregnancy of unknown location? I just wanted to know that difference.
Okay, so pregnancy of unknown location, you will say when you have a patient who has a positive urine pregnancy test, who has a beta HCG, which is in the pregnancy range, but anything more than 15, anything more than 15 or 20, which means that the patient is pregnant. But when you get a scan, you are not able to diagnose a pregnancy anywhere. So what you do is you just have a positive beta HCG, right? All you can do in that situation is get a repeat beta HCG 48 hours later. And depending on the trend of beta HCG, you will be able to probably diagnose what it is. So if it increased to more than 63% or more than that, you're probably looking at a very early pregnancy. And probably over a couple of a week or two, you will be able to see something inside the uterus. Now, if you see something which is probably staying the same, it was 800, it is staying 800, or it is decreasing a lot. If it is staying the same, probably it's a persistent pregnancy of unknown location. But if it's decreasing a lot, more than 50%, so 800, it became 200, 100, or whatever, you probably are looking at something that's going to miscarry. Okay. And if you see a very faint or a slight rise, it could mean an ectopic pregnancy. But till the time you have visualized a pregnancy in the adnexa, or a pregnancy anywhere else, not just the adnexa, in the cervical canal or in the ovary or wherever you're suspecting the ectopic, till the time you've done that, you will not label it as an ectopic pregnancy. So only after visualization on a TVS can we label it as an ectopic pregnancy. Till that time, that will still remain a pregnancy of unknown location.
Thank you for the answer. I just wanted one more thing, the biochemical pregnancy. So does it mean same as ectopic, or it is like pregnancy of unknown location? That's what we say, biochemical.
Biochemical pregnancy is not an ectopic. Biochemical pregnancy is something which probably never gets implanted and never continues, right? So it could fall in the second category, wherein you have a positive beta HCG, but it fell so much that the pregnancy never continued. Somebody who doesn't have questions, please keep your mic on mute. Okay, right. Was I able to? Hi, I didn't catch your name. I'm so sorry. Was I able to answer your question?
Yes, thank you so much for the answer.
Okay, perfect. And your name is?
My name is Nabila.
Okay, perfect. Thank you. So someone has a question. Just a second. Intraresidual and double both in early intrauterine pregnancy. Yes, Mona, that's right. Will we perform laparoscopy if not confirmed ectopic? If not confirmed, I'll just get to that question. Basma, hold that question. We'll go towards the management, and towards the end, we'll come back to your question here. Okay. Salya, if we view trilamina features intrauterine, still consider as PUL? No, we would keep monitoring the beta HCG, yeah? Dr. Basma, I got your question. We'll go through the management and then we'll come back to your question. Okay. Okay. You're welcome, Kausalya. You're so welcome. All right. Okay, so let's move to the management of tubal ectopic pregnancy now. Okay. Before we move ahead, let me just briefly give you an overview of how it is. So we have three options for the management of ectopic pregnancy. The first option is the conservative option, wherein we are not going to do anything. We are just going to monitor the beta HCG, and there are a certain criteria that the patient needs to fulfill to be able to receive this form of management. The second management is the medical management, wherein we give them methotrexate, and for this also we have a specific set of criteria. And the third is the surgical management, and patients who do not fit into the first and the second category usually go in for the surgical management. Okay, now let's please show the slide. Amina, yes, I'm just going to show you the slide. I was just talking about the overview of how it works. Now, let's talk about the conservative management. Okay, so we are going to offer conservative or expectant management to patients who have to be clinically stable. By clinically stable, I mean there should be no tachycardia, there should be no hypertension, there should be no pallor, there should be no signs of any intra-abdominal rupture of the ectopic pregnancy. They should be pain-free. Why pain-free? Because pain is a sign of impending rupture, so they should be pain-free. The size of the ectopic pregnancy is very important. It has to be less than 35 millimeters. There should be no cardiac activity on the TVS. The serum beta HCG level has to be less than 1000, and they should be able to come back for follow-up. If you have a patient who perfectly fits in the criteria but says that, oh, I stay in another city and I cannot come back for follow-up, that means that this patient is not the ideal candidate, and you would not offer conservative management to these patients. Okay. you can consider giving conservative management to patients till the beta HCG of 1500, but ideally the beta HCG levels should be less than 1000 for you to offer them conservative management. Now, the success rate of offering conservative management, it is inversely proportional to the serum beta HCG level. So higher the value of beta HCG, lower would be the success rate. All right. Now, we need to discontinue expectant management if the woman suddenly opts out, if she has significant pain, or if the beta HCG keeps on increasing, or it goes on to be beyond 3000 as we are following them up. Now, we've given conservative management. So we had a patient, she had the beta HCG of 800, she was pain-free, she was fine, the size of the ectopic pregnancy was say 2 into 2 millimeters, and it was all okay, and she was ready for follow-up. We gave her that option and she took it up. What we do next is we get the beta HCG level on day 2, day 4, and then on day 7. Now, if the beta HCG level drops by 15% or more, this is a sign that the conservative management is working, in the sense the pregnancy is ultimately going to abort. And we just keep repeating weekly until we get a negative result. And by negative result, I mean that the beta HCG has to become less than 20 international units per liter. Guys, please keep your mic on mute. I'd be really grateful. Okay. Now, if we see that the beta HCG levels is not dropping by 15%, or if it stays the same, or if it is increasing from the previous value, this means that we need to rethink our decision. We need to review the patient's condition all over again, probably seek senior advice as well, and then decide on further management. Now, the next step in management for us is the medical management. In terms of medical management, what do we give these patients? We give them Methotrexate. Methotrexate is ideally given as a single dose medication, and most of the times it does work. If it doesn't, we have to rethink our decision, probably give them more doses, or probably take them up for surgery. Methotrexate, if the patient is selected correctly, if the patient fulfills all the criteria, the outcome is as good as a surgery. So Methotrexate in certain cases is as good or as successful as offering them a surgery would be. But it should be borne in mind that Methotrexate should never be given on the first visit unless you've confirmed the diagnosis of ectopic pregnancy, and an intrauterine pregnancy has been excluded for sure, because that would lead to termination of the intrauterine pregnancy as well. If there is a doubt, if there is an uncertainty in the diagnosis of ectopic pregnancy, it makes sense to repeat the beta HCG 48 hours later. Now, who do we give this Methotrexate to or medical management to? Now, the criteria for this is women who have no significant pain, women who have unruptured tubal ectopic pregnancy. The adnexal mass has to be smaller than 35 millimeters. There should be no visible heartbeat. Ideally, the serum beta HCG level should be less than 1500, but it could be less than 3500, or it could be less than, you can consider giving it till 5000 as well, but ideally it should be less than 1500. They should not have an intrauterine pregnancy as confirmed on scan and are able to come back for follow-up. Dr. Umelo, hi. Thank you so much for the lecture. Kindly remind us for the formula to... Dr. Umelo, you do not need to learn the formula to calculate the surface area at all, because you're not actually, going to do anything like that in the exam. But if you've come across a question like that, I'd be grateful if you could share it with me, and then we'll discuss that question in detail. Okay, Kausalya has a question. The reduction of 15% by when, expecting to be reduced by second or fourth or the following day? Okay, so Dr. Kausalya, we'll do the beta HCG on day 2. We'll repeat it again on the the second day, fourth day, and the seventh day, okay, like I showed here, you would expect it to fall from second day to fourth day. So if it was, you repeated it here, if it was around 800 and you repeated here again and it fell to 600, the fall in between 2 days, okay, and then you repeat it again on seventh day, and the fall in between day 4 and day 7, that is what you're looking at. All right, I hope you prove to us, ma'am, how much time after administration of alternate days, dear, but the GTG doesn't really mention anything about folinic acid, but practically we give it alternate days. So the next day, first day we give methotrexate, the next day we give folinic acid. I really hope I can, Dr. Mona. Amina, by no significant pain, I mean something that is not debilitating them, something that is not preventing them from doing their daily physical activity. In the question, you can expect something like, if they use words like debilitating, if they would use a word like significant, excruciating, the patient is not able to walk, is confined to the bed, anything like that, which proves to you that it is something that the patient is not able to tolerate, is when you are supposed to not offer medical or expectant. If it's mild on or off pain, if they have used the word mild, then you can go ahead and consider giving conservative management. Use of
Hello, dear participants. It seems like the mentor have lost the connection. Please wait. She'll be joining back. Thank you.
I'm so sorry I lost connection. Sabah, if you're there at the backend team, please make me the presenter so I can share my screen. Oh, here it is. Perfect. Okay, someone has a question here. Provide these slides. Yes, ma'am. Can you please explain second dose when we repeat? And yes, Varsha, I'll get to that just in a bit. I'm so sorry I lost connection. Okay, let's get back to the session. Samreen, yes, I'm still in Pune, but we'll discuss that on a personal chat. Okay. All right. Right. So let's get back to medical management and we'll discuss the questions after this. So when we're offering medical management, we give them IM methotrexate, which is given in the dose of 50 milligrams per meter square of the body surface area. Okay. So day 1, you check the beta HCG, you get the urea and electrolytes, you get the LFTs, you get the full blood count and the blood group, and give the injection. On day 4th, you'll do the beta HCG. On day 7th, again, you'll do the beta HCG. Now you are expecting for it to decrease in between day 4 to 7. So this is what you're measuring. Okay, after giving methotrexate here on day 1, you would expect there to be a fall in between day 4 and day 7. So if the decrease is less than 15%, what we would do is we would repeat the TVS. Why do we want to repeat the TVS? Because we want to see that was this patient a candidate for, probably a surgical management? Did we miss the cardiac activity? Was the size bigger, or was it ruptured, or anything like that? So to confirm that, yes, this person is ideal for medical management, you will repeat the TVS, okay? And if the patient still fulfills the criteria for medical management, you will give medical management. If the fall was more than 15% between day 4 to day 7, then you can just keep doing beta HCG weekly till it falls. At this stage, if it did not fall for more than 15%, answering your questions, guys, and you did a repeat TVS and you thought that, oh, the size is still, maybe 2 to 2.5 centimeters, there's no cardiac activity, the patient is stable, the beta HCG is still 1200, this patient fits the criteria for medical management, yes, you can go ahead and give the second dose. But if you realize that the patient has suddenly developed pain, you realize that, oh, the beta HCG has increased to probably 3,500 or 4,000, or if there are any other features of clinical instability, you would consider this patient for a surgical management. Okay, I hope I'm making myself clear in terms of what we need to do in a medical management. Okay. Now that we've done it, how do we follow it up? If the level falls, we do a HCG weekly, and if it increases, or if it plateaus, or if there's surgical imbalance, we consider surgical management. We've already discussed this point. One thing that I want to say is, okay, I'll ask this question from you. So when we're giving Methotrexate, how long do we tell the patient to not get pregnant?
3 months.
And if the patient does get pregnant within 3 months, would you advise a medical termination of pregnancy?
No.
No, that's perfect.
No.
And how long would you tell the guy to not get pregnant if he was on Methotrexate?
6 months.
Yes, perfect. So for the guys, it's 6 months, and for a girl, if she's on Methotrexate, to tell her not to get pregnant for 3 months. But if she does happen to get pregnant, it is not grounds for termination of pregnancy. Perfect. You guys are already aware of everything, right? So now the success rate of one dose of Methotrexate is between 65 to 95%. And the percent of women who require a second dose is between 3 to 27%. Now there are a few things that are going to predict success of Methotrexate. These are the initial beta HCG level that you do. So lower the level, higher is the success rate. Higher the levels, lower would be the success rate. What you see on scan, if there is a yolk sac, if there's a fetal pole, if there's cardiac activity, these are significant predictors for failure. What I mean by these is, if you see signs which are simulating intrauterine pregnancy, it probably means that the medical management is not going to work. The success rates are higher when no GSAC is visualized. And the pre-treatment changes in serum beta HCG. So if you happen to monitor, and if you saw that the beta HCG increase was very little, it increased only from probably 250 to 300 or 250 to 350, you could expect that, yes, the medical management might work. But if you saw that the beta HCG increased from 800 to 2000, then probably this candidate would not really respond to Methotrexate as much. Okay, so these are the 4 things that are going to predict if your medical management is going to be successful or not. Now, there are a few things that you need to tell the patient if or while they are on Methotrexate, that they need to avoid alcohol and folate containing vitamins. They can have adverse effects like bone marrow suppression, pulmonary fibrosis, pneumonitis, liver cirrhosis, renal failure, and ulcerations. But the most common ones that they can experience is excessive flatulence and bloating, a transient elevation in the liver enzymes, and some sort of stomatitis that they could have because it's an antifolate. And there are some contraindications to Methotrexate as well that you need to be aware of. if the patient is hemodynamically unstable, if there's an intrauterine pregnancy present, in case of breastfeeding, if they are unable to comply with follow-up, if there's sensitivity or allergy to methotrexate, in case of chronic liver disease, if there's a pre-existing blood dyscrasia, active pulmonary disease, if they're immunodeficient, and peptic ulcer disease, okay, because these are all side effects, right? Peptic ulcer disease and liver cirrhosis and pneumonitis, etc. So these are the conditions wherein you would avoid giving it. If they're immunocompromised also, you would avoid giving it. Why these things are important is because, I don't know if you've noticed, but you can see questions wherein they will give you 5 sentences and they will ask you to pick one sentence that is right. So these are the kind of questions or sentences that they pick up from your guideline for questions like that. That's why it's very important to be thorough with the guideline more than going after, summaries. And if you're making your own summaries, there's nothing like it. But always, it might take you half an hour, 1 hour more when you're reading for the first time, but always read the primary source or the primary guideline. Immunodeficiency, dear, like HIV. Malia, immunodeficiency. All right. Now coming to surgical management. So this is quite straightforward and quite simple. So if a patient is unable to come for follow-up, you cannot give them methotrexate, you cannot give them conservative management, you give them option for surgery. If there's significant pain, you give them an option for surgery. If the size is more than 35 millimeters, or if it's larger than that, you can offer them surgery. If you see a fetal heartbeat, and if the serum beta HCG level is more than 5,000, you straight away go ahead and tell them that you will require a surgery. Now, in terms of the surgical management, obviously a laparoscopic approach is preferred over an open surgery. In the laparoscopic approach, if everything is okay, and if the contralateral tube is okay, you would probably want to do a salpingectomy. What I mean by salpingectomy is you would want to go ahead and remove that entire tube where the ectopic pregnancy is present. If by any chance the contralateral tube is not there, because probably there was a previous pregnancy, if the contralateral tube is damaged, if there are adhesions, if the patient is trying for another baby, you would need to do what is known as a salpingotomy, wherein only the part of the ectopic pregnancy would be removed and both the tubes would be sutured, both the ends of the tubes would be sutured back to each other. Right. So in terms of surgery, laparoscopy is preferred, salpingectomy if contralateral tube is normal, salpingotomy if the contralateral tube is damaged. If salpingotomy is performed, 1/5 of these patients may need an additional treatment, probably in the form of repeat surgery or methotrexate. If there is an emergency, if there's severe, if there's the patient is unstable, if there's a large intraperitoneal hemorrhage, if there's, there could be need for doing a laparotomy as well. Okay. So now coming to the follow-up following surgical management. If the patient has undergone a salpingectomy, the entire tube has been removed, there's very little chance that there could be any trophoblastic remains inside the patient, and only getting a UPT after 3 weeks would suffice. But if you are going to do a salpingotomy, that is, remove just the part of pregnancy and suture back the tube, there's a high risk that you are going to leave behind some trophoblastic tissue, and therefore you need to do HCG, beta HCG 7 days after the surgery, and then keep doing it weekly till you get a negative result. And patient needs to be counseled accordingly. You need to tell the patient that yes, there could be, we are doing a salpingotomy, but there could be a need for a repeat surgery. There could be an incidence or a chance wherein some trophoblastic tissue could be left inside, and we will monitor it nonetheless. Okay, now before I go to the next question, I have a question for you all. So this patient is has missed her periods, is 6 weeks pregnant, has an ectopic pregnancy, and the beta HCG is 1000. and she's in no pain. The size of the ectopic pregnancy is 2 centimeters, and she's opted for methotrexate, but her blood group is B negative. Would you give anti-D to this patient or not?
Yes.
No.
Yes.
Okay, so the ones who are saying yes, why yes? And the ones who are saying no, why no?
So ideally, it should be only given when a surgical termination of pregnancy is there.
Okay, and can you source the quote where quote the source where you read this? Amber, right? Yeah.
I think
If patient go to surgery, need anti-D. Medical management, patient no need anti-D.
Okay. Amber says the same. Some anyone who's saying they will give.
I think
Ma'am,
nice
me
guideline.
Samreen.
I think it
Nice-
is an anti-D.
Nice
Ma'am, me
guidelines say that
Samreen.
if you are going for the surgery, and if there is a persistent bleeding, then you have to do then you have to give NTD. Otherwise, there is no need of NTD. It's the nice guideline says that. I have heard somewhere.
Yes.
Ma'am, me Samreen.
Yeah, Samreen, go ahead.
Ma'am, in every ectopic pregnancy, if it is less than 12 weeks of gestation, we are liable to give 250 international units of NTD.
And if it's more than 12 weeks?
Again, between 12 to 20 weeks, again 250 international units. But if it is the ectopic
Hello,
pregnancy,
excuse
it is
me.
yes.
Yes,
It is
Dr.
yes.
ma'am.
Yeah.
Hello, good evening, ma'am.
Good evening.
Yeah, concerning ectopic pregnancy, I think NICE says that irrespective of the method of treatment, and if the patient is resource negative, that anti-D should be given. And it's also, but then in treating any miscarriage, it's also said that though the BASH said that irrespective of method of treatment in miscarriage, that it should the anti-beta D should be given. However, in NICE says that if it's due to medical treatment, that beta anti-D should be excluded. This is actually where they have opposing views.
Perfect. Okay. So let me clear this doubt that is there. So everyone, guys, please go back on the mute mode. So everyone who is saying that we should give is also right, and the ones who are saying we shouldn't give is also right. So what the green top guideline actually says is that we should give it only if surgical management is done. All of you who are saying that anti-D, the green top guideline says that anti-D should be given to Rh negative women who've had only surgical management, because they believe that in medical management there would be no significant fetal-maternal hemorrhage, so there's no need to give anti-D. But in terms of our exam, this is one of the exceptions wherein we would give priority to the British guidelines, which says that in all cases of anti-D, previously non-sensitized cases of Rh negative pregnancy who have undergone whatever treatment, conservative, medical, surgical, whatever treatment, if there is an ectopic pregnancy and it has been managed, they need to receive anti-D. Okay. So this is what the GTG says. Only the ones who've had a surgical procedure. Okay. But this is what the BCSH guideline says. Okay. That there's a significant potential for sensitization in cases of ectopic pregnancy. A minimum dose of 250 international units should be administered to all cases of ectopic pregnancy in a previously non-sensitized D negative woman, regardless of the mode of management. Okay. So this is from the BCSH guideline, and this is what we need to follow for our exams. So whatever way the ectopic pregnancy has been managed, we will give anti-D. Okay. I hope from this, after this session, there will be no confusion about anti-D in ectopic pregnancy. We will give to all. All right. You have, Arsa, you have to answer that you will give to all Rh negative patients who've been managed, irrespective of the mode of management, medical, surgical, whatever it is, you will give anti-D, 250 international units. Okay, dear? Okay, Samreen, perfect. Okay, Dr. Seema. Hi, nice to see you. I hope you're doing great. All right.
Hi, Pradnya. How are you?
Hi.
I'm fine, dear. I just saw that you are host and talking. I said I will join. God bless you. That's nice topic. Thank you, Pradnya. Thank you.
Thank you. Thank you. Thank you so much for being in the session.
My pleasure, dear. Thank
Yes.
you.
Long time.
Yes, long time.
We'll chat after the session.
Okay.
Hi, hello, Sama. Hi, I hope you're doing great. Yes, Mona, even conservative, if there has been a diagnosis of ectopic pregnancy and if it has been managed, conservative, medical, surgical, whatever it is, we will always give anti-D, dear. Okay, I hope this is sorted. Right. Now let's look at what happens to the future fertility prospects. Okay. So if this patient inherently has had no issues of subfertility or no issues of any tubal pathology, there is going to be no difference in the rate of fertility and the risk of future tubal pregnancy. It's all going to be the same, irrespective of the way you manage it. For example, you had a 23-year-old patient and this is her first pregnancy and it happened to be an ectopic pregnancy. So you need to tell her that irrespective of the way that we manage your pregnancy, be it conservative, medical or surgical, your future fertility and your future risk of tubal ectopic pregnancy and tubal patency, none of that is going to depend or change based on how we are going to manage you. But yes, if a patient has had previous history of subfertility and if the patient is dealing with subfertility, offering them an expectant or a medical management is better because that is associated with improved reproductive outcome as compared to a radical surgery, that is doing a salpingectomy. Okay, I hope these two things make sense to you. If a patient is normal, has no risk factors, no subfertility, then the mode of management doesn't really make a difference. But if the patient has had previous subfertility, then an expectant or a medical management is better in terms of future fertility outcome. Okay. Also, patients need to be told that Methotrexate is going to be having no effect on the ovarian reserve. And after having gone through treatment with uterine artery embolization or systemic Methotrexate for non-tubal ectopic pregnancies, the live birth rates have been reported and they can still get pregnant. And laparoscopic management of ovarian pregnancies, they have a good future fertility prospect. Okay, so this was regarding future fertility prospects and the different specific ectopic pregnancies. I've saved it for the session. I'll soon have the early pregnancy module discussion wherein we will discuss all the different type of ectopic pregnancies that are there: cervical, interstitial, abdominal, heterotropic, and we'll go into the detail of that. But otherwise also, if any of you have any questions about anything in terms of ectopic pregnancy, you can always get in touch with me. Before we move on, I have some questions and I would want some volunteers who would want to take these questions for us. No one is interested in doing any questions? Yes, sir. Okay.
Yeah.
Okay, Mariam. Annette, I'll show you you want to see the initial few slides? I'll show it to you after the questions are done here. Okay, do remind me and I'll show you then. What about Methotrexate in heterotropic pregnancy? In heterotropic pregnancy, you should never give Methotrexate there because you want the intrauterine pregnancy to continue, right? So the most appropriate management in a heterotropic pregnancy is probably going in surgically and removing that. If it's a very early ectopic and if the even beta HCG is not going to help. So if it's a very small pregnancy, you can do a conservative management and see if it's getting resolved on its own. But if it's not, the next best option would be probably injecting KCL or going in surgically, but definitely not Methotrexate for heterotropic pregnancy. Dr. Basma, please can you repeat the part of anti-D? Okay, dear. Very simple. As a rule, we will give anti-D 250 international units to all ectopic pregnancies, irrespective of the way that we manage them. So conservative, medical, surgical, all would receive anti-D. As I got, anti-D is given to all ectopic cases. You're absolutely right, Dr. Basma. Okay, that's perfect. Right. Okay, so let's start with the questions. Kiddo studying too much background noise. No problem, no problem. That's absolutely okay. So who do I have the first one to solve the question? So one of you will do one question each. Okay. Okay, someone has a question. I didn't attend the lecture, just came at anti-D. Salma, I'm sure you'll manage. And even if you go wrong, this is not an exam, right? We are all learning here together. So it doesn't matter. Okay, Esma, you can take the first question here. And then Sama, you can take the next question. All right. This is your question. Read it out loud. And then we'll discuss the answer. I don't hear anything. Irsa, are you reading? I'm asking you to unmute.
Yes.
Yes, dear, go ahead.
Okay. 26 years old patient present with left iliac fossa pain and has a 6-week period of amenorrhea. The patient is clinically stable and ultrasound confirms the presence of left side ectopic pregnancy. There is 2 by 2 by 2 cm pool of free fluid in the pouch of Douglas, and the serum beta SCG level is 3,500 international unit per liter. What is the recommended management? Okay, left laparoscopic salpingectomy if the contralateral tube is healthy, left laparoscopic salpingectomy, left salpingectomy via laparotomy, methotrexate, repeat beta SCG level and manage accordingly. Okay, she has pain and she is 6-week period amenorrhea. Clinically stable, ultrasound presence of left ectopic, there is 2 by 2 cm pool of free fluid and 300. Okay, we can go for methotrexate.
Okay, and why do you think we should go for methotrexate?
Because the level of the beta SCG and she is clinically stable. Only with left iliac fossa pain.
She has pain, and there's fluid in the pouch of Douglas, so the patient is not fit for methotrexate. I think the answer is A.
Yes. So
the answer is A.
I support also
A. Answer is A.
Correct. Right. So let's justify why it is A. Okay. First, the beta HCG is 3,500. It is recommended that it should be less than 1,500 for methotrexate. It can be considered, but you would never go for considered if you have something that is already recommended. Okay. So that is the first thing. The second thing is there is free fluid in the pouch of Douglas, which probably means that there is there could be a rupture, but not necessarily. Okay, it could be reactionary as well. And the next thing is pain, but even this, they don't say that it is significant. But the most important reason why you want to go ahead and do the salpingectomy is because of the beta HCG level. Okay, I hope before I move ahead, I want to understand what do you understand by recommended and considered or offered? Recommend and offer. Okay, so recommend is something that has to be done, that is to be followed as a rule, but consider is done in situations which are exceptions. Somebody who's absolutely not willing for surgery. So if this mentioned here something like this patient is not fit for surgery, is not willing for surgery, something like that, then you could have thought of methotrexate. Okay, but the best thing here right now, the single best answer would be a salpingectomy, okay, and not methotrexate. All right, dear?
No, mom, I didn't understand. It say
Okay.
like the patient is clinically stable,
Yes.
and so why not Methotrexate?
But what is the beta HCG for offering Methotrexate?
1,500.
Right. And the beta
But-
HCG here is
3,500.
right? That is the first most important thing. Second thing is there is free fluid in the POD, which could probably mean that there is a rupture, most not likely, but it could be. So these are the two things why we would consider going in for a laparoscopic salpingectomy and not Methotrexate. Consider, Mariam, consider.
So it's according to beta HCG level here in this case.
Yes, in all the cases, you have to take all the things into consideration. Okay, let me go back to the slide of medical management. Okay. Right? So we are here. So serum beta HCG level has to be less than 1500. Okay. If everything is ideal, you would go with what is recommended. Okay. You can consider 5,000. I understand. But consider when this option of surgery is not there. Okay.
Okay,
if
okay.
said that I do not want surgery, then you could consider Methotrexate. Right?
Okay.
But when there is an option for surgery, go ahead with that, dear. Okay?
Okay. Thank you, mom.
Okay. Great, great. All right. Next question. Who's going to do the next one?
Me, ma'am. I'm Dr. Sam. Yes.
Okay, perfect. Okay. Okay. There you go.
Okay. A woman who has had a left salpingectomy previously for ectopic pregnancy has now been diagnosed with an ectopic pregnancy in the right fallopian tube. Laparoscopy is performed and the surgeon opts for salpingectomy as the woman still wishes to become pregnant. What is the possibility that she will require further treatment, Methotrexate or salpingectomy? That is 20%, ma'am.
That's perfect. That was very quick. You didn't even go through the options.
Yeah, because I remember I read this topic just recently.
That's perfect. That's great. It's 1/5 or 20%. Okay,
Thank you,
that's amazing. Thank you. Okay, Khadija has a question. Clear it again. Difference between recommended and considered. Okay, Khadija, recommended would be a rule that needs to be followed. For example, if something that the college is saying that this is the ideal and this is how it is to be done, right? For example, in ectopic pregnancy itself, if you get a beta HCG of 7,000, would you consider offering medical management? No, right? If the beta HCG is more than 5,000, you know that the only way out is doing a salpingectomy. So that is recommended, okay? Where you know this is the thing that has to be done. So medical management has to be done or has to be recommended less than 1,500. It can be considered in the sense in exceptions where the situations are not ideal, where you cannot do the ideal thing or you cannot do what is recommended because of whatever reasons. For example, the patient is apprehensive for surgery, does not want surgery, is not fit anesthetically, whatever reason, then you can consider the next best option. But considering is not the ideal treatment that you're giving to the patient. Okay, it is because of circumstances. So recommend is something that needs to be done. Consider or offer would be the second best thing. Okay, so if you have in the option the best option or the best thing that can be done, then choose that. Okay. All right, next question. Who do we have here? I hope that answers your question, yeah.
I can do one question.
Yes. Who is it? I didn't get your name. Maya. Okay.
Maya.
Okay, perfect. Right, there you go.
20-year-old woman present to the early pregnancy unit assessment unit with abdominal pain. An ultrasound scan reveals left tubal ectopic pregnancy of 3.5 by 3 centimeter. She undergoes laparoscopy and the findings are as follows. Left tubal unruptured ectopic pregnancy of 3 centimeter with normal right fallopian tube, minimal endometriosis in the pouch of Douglas with extensive bowel adhesions on the right side due to previous appendicectomy. Uterus is bulky but normal. How should she be managed? Left salpingostomy with treatment of endometriosis. Left salpingectomy with adhesiolysis. Left salpingotomy with adhesiolysis and treatment of endometriosis. Left salpingectomy. Abandon laparoscopy and treat with medical management, that is methotrexate. So this lady is having pain, and she is having the size as 3.5 by 3. She is having unruptured ectopic of 3 centimeter. Now 3 centimeter is the ideal word with normal right fallopian tube. There is a minimal endometriosis in the pouch of Douglas with extensive bowel adhesion on the right side. Okay. So, and she is also having previous appendicectomy. So definitely then this patient will not be the candidate for salpingectomy. We should go with salpingostomy on the left side. Now the question is whether we should treat the endometriosis or no, because she has got the extensive bowel adhesions on the right side also. And you have, I don't know whether you have consented the patient or no. That's what I'm thinking. So left salpingostomy is the answer, that is true. But whether we will do the treatment of endometriosis or no.
I'm really liking the thought process and how systematically you're going. But
it's just that there is a minimal endometriosis. I'm a little confused about, because there is a previous appendicectomy, there is extensive bowel adhesions. But my concern is we have not, when we take the consent of the patient, we must not have consented her for this endometriosis treatment. Correct. So ideally, we should not do the endometriosis treatment. So that way, if I'm thinking, my 2 options are, anyways, 3 options are already going. Mm-hmm. But their salpingostomy is only with these 3 options.
Okay.
And I'm left with D and E actually.
Okay, so before you move ahead and get into endometriosis and ESHRE and clinical governance, did you happen to read this?
Yeah, I saw that, and I'm thinking from that only. I'm thinking about option D, that there is a normal right fallopian tube. I got that point. So ideally, then we should go with, as per the protocol, if you follow, then ideally you should go with only salpingectomy on the left side. But at the same time, I'm also thinking that this lady is having endometriosis. So
you don't treat it because, like you said, no consent.
Yeah.
So the left salpingectomy is the right answer. So go as per the protocol. Okay. Always don't think clinically in part 2. Okay. Only in part 3. In part 2, only think guidelines. Whatever the guidelines say. This was a very tricky question, but everyone who said D, amazing. As in initially Dr. Seema, iPhone 4, I don't know who that is, Aniet, and Dr. Omelo, amazing. That's great. So a very tricky question because it makes you believe that there is endometriosis on the contralateral side as well, right? Adhesions on the right side. But this is bowel adhesions. The right fallopian tube is absolutely normal. So we'll go in, we'll do left salpingectomy, we'll come out, we'll counsel this patient and tell her that, this is the concern, and probably, go in and endometriosis not always and not necessarily needs to be treated surgically always, right? There's a lot of medical management that you always initially give till there is actual concern or a need for a surgery. So for now, for this question, you would just do a left salpingectomy.
Yeah.
Okay. I hope this question helped. All right. So who do we have for the next question? Yes, Maliha, it was a tricky one, dear. All right, next question.
I can read Dr. Pradnya. I can read the next question. Okay.
Perfect. Yes.
All right.
There you go.
Yes, a 29-year-old. She's 6 weeks pregnant. She's diagnosed to have a right tubal ectopic pregnancy by transvaginal pelvic ultrasound. Which one of the following factors would enable systematic methotrexate to be offered as the medical treatment option for the ectopic pregnancy? So the criteria is just explained here. Ectopic adnexal mass, which is 5 by 4 cm in size. Initial serum beta HCG 1 to 50 unit. Presence of fetal heartbeat in the ectopic pregnancy. Ultrasound evidence of hemoperitonome above 50 ml. The woman has had previous salpingectomy, so further salpingectomy surgery is contraindicated. So it said, according to the condition, which one is good candidate for methotrexate treatment. Above in these all options, the best one is option B, because, for example, the mass of 5 centimeter is large size, is not good candidate for methotrexate. Presence of fetal heartbeat is another contraindicate for the methotrexate. Ultrasound evidence of massive hemoperitonome is another contraindicated. And also when the woman has the previous surgery. So the best one is Dr. Pradnya is option B, I think, because the level is below 1,500. This is my answer.
Yes, that's perfect. That's the right answer, and I was sure that you would answer correctly. Okay, we have one more question. I think this is the last one. Who will want to read this out? Okay, Irsa, you can go ahead. I hope I'm pronouncing your name right.
A 29 years old who has 6-week gestation, present with slight vaginal spotting, transvaginal pelvic ultrasound shows no evidence of any intrauterine or extrauterine pregnancy. Serum beta HCG is measured at initial presentation and repeated 48 hours later. Which one of the following beta HCG result is suspicious for clinically significant ectopic pregnancy? Okay, 500 and then 1,200, 800, 200, 1,400, 1,000, 3,000, 2,000, 2,500. Okay, for ectopic, it should be decrease less than 500 or raise less than 63. So I will go for option A, 500, 1,200.
What about E?
E is correct.
Yeah, I see. Yeah, the best answer is E, not A. A could be, it can go with it can go with normal pregnancy. So
Correct.
yeah, the correct answer is E.
Yes, that's perfect. And everyone in the chat box also answered E. So yes, E is the correct answer. Okay. All right. Thank you so much, guys, for being so active and answering, and even everyone in the chat box who was so active. Dr. Sucheta has a question. In such cases, we should calculate and check to answer. Yes, obviously, you have to double and see, double more than 6, whatever is more than 6, would probably go into your time. Okay, Mariam, I'm going to mute you, dear. Lots of background noise. Okay. So, Dr. Sucheta, is my voice clear now? Yes. Okay. Thank you so much. We've not finished yet, guys. We'll just touch upon how to prepare for part 2. We'll just get there in a bit. But before I answer Dr. Sucheta's question, yes, we'll calculate and then check the answer. And it wants the first 3 slides. Thank you so much, Mona. I'm glad that it was helpful. First 3, yes, I'm showing you, dear. Give me 2 minutes. Let me go back. This one. Dr. Romelo, you're welcome as always, and it is great to have you on the session and great to have interaction with you. And it is this the one that you want? This one. This one? Can you share your presentation, please? Slide for Methotrexate. Yes, Mona, 1 second. And this one. I hope these are the ones that you're asking for, dear. Okay, somebody said the slide for Methotrexate. This one? You're welcome, dear. I hope it was helpful. Yes, Malia, it'll be available on YouTube. And if you're on the course, it'll be up on your portal as well. Mona, I hope this is the slide that you're looking for.
Dr. Pradnya, could you please quick re-explain the last question? I wasn't so clear why we choose option E.
Yes.
Can you, because of, I need your explanation. Thank you.
Of course. Okay. So if it is an intrauterine pregnancy, when we are repeating beta HCG 48 hours later, the beta HCG levels would increase by 63%. So in the first scenario, in the third scenario, the beta HCG rise was more than double or more than 63%. So these two conditions probably indicate towards an intrauterine pregnancy. Now coming to the next two ones, there was actually a fall in beta HCG, which was more than 50%. So these two indicate something like a miscarriage, something like a pregnancy, which is not going to continue. Now coming to the last option, here the rise was not more than 63% and there was no fall. So this fits the best in terms of a ectopic pregnancy. Thank you so much, Khatija.
Okay. Thank you, Doctor.
Yes, thank you. All right, thank you, Dr. Seema. All right, so don't leave yet. We will just touch upon, for people who are new, for people who do not know how to go about the part 2. I just want to say that, yes, this is a really difficult exam, and but this is definitely not something which is impossible. If I think I could do it, anyone could do it, and just a little bit of direction is needed. And what the part 2 exam actually has is, this exam is a computer delivered exam now, and you have to book your exams through the Pearson VUE Center. You have to book a center for yourself. You go there would be a computer in front of you. There would be a sheet of paper or a marker wherein you can write and erase. You will have 2 papers. There would be a paper 1 and paper 2. There would be a break in between both the papers. Each paper would have SBAs and EMQs, all right? And surprise gift. Yes, it's going to be there for you all. Just hang in there for another 10-15 minutes and it'll be there for all of you all. All right. So there's going to be SBAs and EMQs. SBAs are important, but they constitute only 40% of the marks, and EMQs constitute 60% of the marks. So even though there's no specific time divide, but it would be wise to spend almost 70% of your time on EMQs and rest 30% on SBAs, because as soon as you see it, you most probably know the answer to it. The duration of each paper is around 3 hours or 180 minutes. And the criteria for passing is a standard setting, in the sense it's a criterion referenced exam. The top 1/4 of the people will clear it. So how everyone else perform also decides who passes and who doesn't. So in SBAs, you have to pick the most likely option there is. It doesn't have to be the right answer, but the best out of the options that are available. In the extended match questions, there are going to be 10 to 14 options for you. The best way to solve an extended match question, according to me, is probably to first not read all the 10 to 15 options that are there. First, go and read the question, okay? And as soon as you've read the question, you will have a tentative 1 or 2 answers in your mind. And then you go through the options and you will be able to find out the right option. Never sit and waste time in reading the options, because that are always given first. In the computer-based test, that is not the problem. You read the question and below the question, there would be answers. Okay, so that is a good thing about the computer-based test. Again, there are no negative markings, So you should attempt all the question. Now, the study material you all know is the Green Top Guideline, which has the highest priority, the NICE guideline, and the TOG articles. And then there are small articles like the SIPs, FSRH, BASH guidelines, MABRACE, and on the website, we have summaries for everything. So these you can read the summaries, but for the GTG NICE, I would suggest you read the entire guideline because that is extremely important. Even TOG articles, you can, just go through the flowcharts and the pictures, but GTG and the NICE guidelines, please, at least the first time that you're reading, read it thoroughly and make out your own personal notes. They're going to be precious for you. I still have mine and I refer to them whenever I'm teaching. So they are, yes, Dr. Rosina, it's 180 minutes there.
Do we have to read the recent 2-year TOGs or all the TOGs are important?
We do have a list of the important TOGs which I'll share in the group, but last 2-year TOGs are important. More than that, the TOGs which do not have any specific guidelines, like for example, cystic fibrosis doesn't have a NICE guideline or GTG, right? We have TOG articles for myocardial infarction, for cardiac disease in pregnancy, these kind of things for which, like asthma, there are no proper guidelines for them, like there's no GTG and NICE. Those I believe are the most important and they do always target them. And in terms of your subfertility module, there are a lot of important TOG articles. In your urogynecology module, there are a lot of important TOG articles which are shared on the drive if you're on the course. So those have to be done. There's no two ways about it. But yes, a lot of new TOG articles are there which might not be very important. So Dr. Seema, thank you so much for being on the session. It was, as always, great being with you. Okay. So those are the TOG articles which will be important here. Yes.
Among the TOG, like for January exam, the last TOG which we should read will be July or whether it will be September 1.
I'm sorry, I didn't get your question. The last TOG article?
So for example, if you're preparing for this January, the last TOG I think which came is in the month of September.
Yes, it recently
whether
came out.
Whether that will come in the exam or no, I mean
unlikely, because they would have set the paper already and they wouldn't include something so recent and they wouldn't expect you to know something so recent. So very unlikely. Don't read the ones that is just released.
Okay. Thank you.
Right. Yeah. All right. So how to actually structure and be efficient in studying? Or basically what I did when I was preparing, I started in September and my exam was in January. So I had very little time. But I did make sure to read the guidelines, at least the Green Top guidelines and the NICE guidelines very thoroughly, because those you have to know, and that is something which everyone will answer. And if those are the questions which you don't answer, that will reflect very poorly. If you do not answer a question from TOG, that's okay. But if you don't answer a question from GTG and NICE, that's not okay. So always finish these first, be very thorough with it before moving on to TOG articles. All right. Read those guidelines, make your notes, make sure the recommendations are crystal clear. Add points whenever you're solving questions. If you find something new, add it on to the notes. If you're reading a TOG article which is relevant to heavy menstrual bleeding, if you're reading fibroids, add it on to the notes. So during revision, you have something very concise and something that is all together at the same place. That will really help you revise. And the most important thing is to keep going back. If you read a topic today, tomorrow, take out 15 minutes, go through it before you start a new topic. 1 week later, go back, take 15-20 minutes, just brush through whatever you read, because these exams of these topics are extremely volatile. If you do not go back and forth, I think you'll really forget it. SF, yes, I will do that. So TOG articles, what they actually look from us in TOG articles is they have a lot of tables. Okay, the tables that they give there are very important and the most important parts of it. For example, if you're doing the borderline ovarian tumor TOG article, right? So there's a flow chart that they have. what I did, I took a printout of the flowchart of the management, and there were incidences which were important on it. And there were, whatever other things that I found important, this patient needs to be managed this way, this patient needs to be managed conservatively. I took a printout of the flowchart and I jotted down those points. So the entire thing became one sheet of paper. So that was borderline ovarian tumor for me. And first time when I was reading, probably it took me 2.5, 3 hours to read it. But next time to revise that one sheet of paper, it would take me 15 minutes. And if I read that 4 times till exams, my borderline ovarian tumor would be thorough. Okay, that is just an example of how to efficiently read it, because every time if you go back to the original article, you are going to miss out on a lot of time, and it's going to be very boring. You'll be like, I've read this article, there's nothing new, but what actually is important, you will not pay attention to it probably, right? So make concise notes, make notes which is very important and something that you can read again. Probably use more different color codes, something that'll make it interesting. Do make your own notes. Okay, I hope that answers your question. Okay, SF, I didn't get your name. All right, Shabana. Okay, I hope that answers your question, Shabana. All right, a few important or very important points that you need to know is algorithms. They will ask questions from algorithms. They'll ask EMQs especially. You need to know how to manage shoulder dystocia, and you need to know this is the first point, this is the second point, this is the third, and this is the fourth point. You need to know when you're managing a postmenopausal ovarian tumor, when you need to do a CT and when you need to refer. Okay, so this will come only when you are thorough with EMQs, when you're thorough with the flowcharts. The best way to do it is make those flowcharts and paste it on your wall, or paste it, or have a folder which you revise frequently. Okay, very important. Incidence and percentages are increasingly becoming less important, but the ones that the college is favorite, or the one that college likes to ask, they will ask it, and you cannot get it wrong. Okay, in my exam, they asked about the incidence of shoulder dystocia, and I'm sure they've asked it 10 times before. So be thorough with those kind of things. There are no GTGs for subfertility, for interpartum guidelines. So guidelines that do not have any GTG, like for urogyne, do make sure that the NICE guidelines are thoroughly read. NICE guidelines can be a little difficult to decipher, right? To figure out what they're trying to say. So the sessions come in, help them. We try to summarize everything. We try to make everything palatable. Like, I hope ectopic pregnancy was a little easier, a little more interesting for you all. So sessions come in handy then. Okay. Talk articles become definitely more important. Focus on the tables and the algorithms, and of course the cervical screening program. Revise it, revise it, revise it, discuss it. Do not solve old questions. They will just confuse you. Just take one person as your study buddy and keep asking the person what is the next step that you will do. There's a patient who's gone, then the HPV that is come positive. What would be the next step that you will do? Okay, so keep doing this to revise the cervical screening program. That's the only way to do it. All right, the 14 modules, I am sure you're very well aware of the modules that are there. What's ANT recalls? I didn't get your question, Shabana. And recalls. What about recalls? I'm so sorry. That was a typing mistake. Well, to be completely honest, when I was preparing, I did not even solve one recall paper, primarily because the questions that were there in the recalls used to irritate me to no end. They were very ill-formed, the keys were very funny, and I used to not enjoy solving them, and I didn't have any time to sit and do that. So instead of doing that, I solved strategy. And trust me, I didn't solve any recalls. But yes, how you can utilize recalls is by seeing what kind of topics that have come previously, but please don't rack your brains in questions that are confusing. Some 10 different people are giving you 10 different keys, and you're fighting about it will take you nowhere. Okay, one question which is extremely weird, which nobody knows about and which everyone has a confusion about, forget about it. Okay, in that time you will read 2 guidelines which will actually fetch you more marks, right? So for me personally, I do not like solving those poorly framed recalls. It gives me a headache. But yeah, to each their own, right? So there are so many books that are there, and the really good ones are quite old, but I really like the question quality that is there in Tahir Mahmood, in Rekha, in Succeeding. The keys could be wrong in terms of the current guidelines that are there. The keys could be slightly old. If you find that the keys are not according to what you think is the right answer, go back to the recent guideline, check the answer. You probably are right and the key is wrong, okay? But don't not solve these books. These books are extremely important and we do solve them on our course as well. And yeah, basically books and strategy. Okay, strategy is amazing. There is no way that there is going to be any wrong key and any confusion like that. So how do you take lectures? How to take your lecture regularly? Khadija, you can get in touch with Anum. She's there.
What do you mean strategy, doctor? What is this strategy?
I'll just a second. I'll tell you. Let me just answer Khadija's question. Yeah, so Anum will get in touch with you. Perfect. Who was asking about strategy?
Yes, what is this strategy, doctor?
That is the e-learning platform from RCOG. Okay, so this is the website that I've shared here. It is their portal, the college's portal. They provide questions there, they provide explanations and answers and all of that. And that is the best source to solve questions because there's no way that the key is ever going to be wrong. A lot of times they take out questions directly from there and put it in your question paper. So it's a great, way to practice and a very good pool of questions. So you can definitely subscribe to it and, you know, it will help.
Okay.
All right. So that is the strategy or the RCOG e-learning, as you can see from here. All right. And this is what our portal looks like, wherein you have the sessions that we take, the recorded sessions are available, all the guideline summaries are available, all the videos are available, which I've recorded in my own voice, a few by my co-mentors with me. There's Dr. Zaib and Dr. Mohammed Hassan. Mohammed Hassan, sir, is RCOG examiner. He's still, conducting exams, very senior, and always so much to learn from them. And well, this is what I want to tell you. I want to tell you that only yesterday we have started our schedule and we've started actively preparing for the July 23 exam. We've started discussing with the epilepsy green top guideline. Along with that, we've done the talk as well. We have a Telegram group wherein our students are discussing the guidelines on a daily basis. And we have these sessions like the one that I took today. We do it either weekly or once every 10 days, depending on our schedules. And we solve all the modules there. Me especially, I like doing a lot of questions. So we solve questions also online. And if you want to know more about the course, you can get in touch with Anam. She's right there. And for people who are Rosina L. Pop, which schedule we will be following? Okay, we can share the PDF of the schedule that we are following, and I will share it with you if you want. For the ones who are appearing for the Jan exam as well, there's a progressive course that is going on. For that, you can get in touch with Anam. She'll be able to guide you more. So really looking forward to having you guys with us and having more such sessions with you all on the course, and hopefully I'll be doing more such live sessions. If you have any topics in mind which you want me to do let me know, and I'll take those sessions the next time. And just want to say that I am so glad that so many of you all turned up for the session. It was very fruitful for me as well. I thoroughly enjoyed discussing questions, talking to you all, and doing ectopic pregnancy. Early pregnancy module is my favorite, so it was great. Thank you, Shubhana, and thank you so much, all of you, for being with us. If you have any Okay, so here is the surprise. Whoever was there with us till now, they can avail a $200 off on the premium course for July. Requested from the management, and they were kind enough to allow me this. And I'm really glad, and I want to share with all of you all for being with me till now. And it's been a very nice session, and I'm really glad that we did this. Hoping for more such sessions soon. And you all can avail this discount by getting in touch with Anna, who will be able to guide you. That's great, Sabreen. I hope it helped you. And if you have any questions, you can always get in touch with me on Facebook, on Telegram, or on the group, the guide group. I'll always be there. Thank you so much. Wishing all of you a best of luck for your studies. And I hope that you all come out with flying colors. And do let me know whenever you need me. Thank you so much. Thank you, Samreen. Thank you, Suma. Thank you, Manisha. Thank you, Shanaz. Thank you, Anam. Thank you so much for being with me on the backend team and for supporting me throughout as always. Thank you. We'll share the Telegram group link. Yes, we will share it with you here. Thank you, Maliha. Thank you so much. Thank you, Annette. I hope it was helpful. Thank you, Namri. Thank you, Rosina. I hope the session helped all of you. Thank you. Hopefully, I'll see you guys again very soon. Thank you, Dr. Iram. All right, I'll see you again soon. Yes, definitely more in the future. Thank you, Sama. Thank you so much. All right, bye. Bye, doctor.